My name is Radek Skoda from University of Basel in Switzerland, and I was asked to review new mouse models of myeloproliferative neoplasms, and I try to convince you that mouse models are not only interesting for addressing basic questions, but maybe also relevant as preclinical models. So, myeloproliferative neoplasms are relatively simple disease when it comes to the actual driver mutations. And as you know, there is the onset of MPN usually coincides with the acquisition of one of today 3 different driver mutations. Most prominently, JAK2 mutation, which is acquired on chromosome 9, then defines a heterozygous clone that proliferates in some patients, becomes homozygous, and as we know, the homozygous clone is somewhat associated with the polycythemia phenotype, whereas the heterozygous state is more associated with the ET phenotype. So today we have 3 driver genes, and I will review them. One is JAK2 mutations, calreticulin, and MPL thrombopoietin receptor. You've also nicely heard in Luca Malkovati's presentation that there are additional mutations, and actually the genes mutated in MPN are frequently the same as in MDS and also in acute leukemia, and most of them we think are involved in disease progression. We also found early on that some mutation can precede the acquisition of the driver mutations, and in fact the same gene in some patients can precede, and in other patients can come after the acquisition of driver mutations. And today this clonal hematopoiesis as a pre-MPN phenomenon has been firmly established through the sequencing in elderly patients with otherwise normal hematopoiesis. And so the 3 driver mutations are depicted here, and they all center around the 3 main signaling pathways that regulate the numbers of platelets: the thrombopoietin with its receptor, red cells, erythropoietin receptor, G-CSF and its receptor. And you can see that all these 3 receptors are signaling through association with JAK2, the Janus kinase, which is necessary for signaling through all 3 types of receptors. And as you know, the mutations in JAK2 most frequently in the 617 position, but also in exon 12 and other positions as we sequence more and more of patients. And these mutations are somatic mutations in most cases, and originally they are in a heterozygous state. This acquisition of the heterozygous mutation then leads to hypersensitivity to the ligands of these 3 receptors, and there's some variation as to which of these 3 receptors is stimulated at what level, and therefore the mutations in JAK2 are phenotypically the most diverse. We have some patients that respond in all 3 lineages, polycythemia vera. Others respond with platelets and granulocytes, and this dominates the phenotype. You know that the mutation can become homozygous, and in the homozygous state, the erythroid lineage then is more strongly activated. So the diversity comes from the JAK2 being involved in these 3 different ligand receptor pairs that govern the production of blood cells. MPL, the thrombopoietin receptor, can mutate itself. As you know, the mutations are located just inside the cytoplasm, and they make this receptor partially independent of the ligand. Since MPL is expressed on stem cells and later is restricted to megakaryocytic lineage, the phenotype does not include the red cell lineage, but rather results in an ET or PMF phenotype. And finally, calreticulin completes the story, as has been nicely shown by the groups of Robert Kralovic and William Weinschenker, Stefan Constantinescu, and others, is that calreticulin is a chaperone, is a protein that looks for the proper folding of proteins such as these receptors that are destined to be expressed at the cell surface. Now, the extracellular domain of these receptors actually stick in the lumen of the endoplasmic reticulum, and that's where calreticulin binds to these receptors. This is a normal process. However, when calreticulin is mutated, calreticulin not only binds these receptors, but also, through mechanisms we don't understand, also activates signaling of these receptors, and so the mutant calreticulin becomes a false ligand and stimulates the same receptors that we've seen here, and the result is increase in platelets and to some degree also granulocytes, and again we have ET PMF phenotype. So this is a nice convergence of the molecular mechanisms of the driver genes that are involved in pathogenesis of MPN. Also explains why JAK2 inhibitors actually inhibit all kinds of mutated driver genes. Now, the mouse models that have been generated for the JAK2 mutation mimic the variability of phenotype that we see also in patients. Here is plotted platelets, and we consider mice that have increased numbers of platelets as ET as long as they don't have increased hemoglobin, whereas we call everything PV that has high hemoglobin red blood cell mass, irrespective of whether the platelets are normal or elevated. So the initial models that have been created were using retroviruses, and these models almost invariantly increased the hematocrit but had a normal or even slightly lower platelet numbers. Later, and there were some minor differences between using the mutated mouse JAK2 versus the mutated human, which is here in yellow. Then came some transgenic models, and these then widened the spectrum of phenotypes. Some mice models developed ET with a high platelets but normal hematocrit. And this was true for both using the mouse and the human mutant JAK2. Then my own group generated some back transgenic mice, and these developed mostly PV phenotype, but we've shown that this can then progress to a pure ET phenotype, depending on the levels of expression of this mutant protein. And the last generation of models were knock-in models that used the mouse mutant JAK2, and they created a strong PV phenotype with some variable, but in general also increased platelet levels. Finally, there was a knock-in with the human JAK2 from the Cambridge group of Tony Green. In the heterozygous state, these mice had almost no phenotype, and the homozygous mutant then develops a PV phenotype. So these were the V617F models, and finally we generated also a mouse model for the exon 12 mutation, and this mouse reproduces the phenotype we see in patients, which is a almost pure red cell proliferation. So here are the models for the second driver gene, MPL, the thrombopoietin receptor. So far, the models have been using retroviral transduction, and these models do not completely faithfully reconstruct the disease we see in patients, because when you introduce the MPL, the mutant MPL, using a retrovirus, you actually do not get an ET phenotype. You get very high white blood cells. You also get an increased hematocrit, and of course you get very high platelets. And this is due to the fact that you now direct expression of this mutant protein into lineages where it's normally not expressed, because the retrovirus doesn't know where it should express, and therefore the phenotype is much wider than what is normally restricted by the lineage-specific expression of this receptor. These mice die in a very short time. It's a useful model to study myelofibrosis. It's a very rapid model, but one has to keep in mind that it is not a very physiologic model of this type of disease. And finally, we have mouse models of the calreticulin mutants here from work of Caroline Marty from the Paris group. You can see that the two types of mutations have different phenotypes. So the more frequent deletion of 52 base pairs has clearly elevated platelets, whereas the insertion 5, the type 2 mutations, has a much milder phenotype. This mutation then results in myelofibrosis, and you will hear more about these models in the subsequent talk by Jean-Luc Villeval. So these are the models, and now we'll go a little bit more detail into our own model of the V617F mouse. We generated the human JAK gene, mutated it, and put it into the mice in a way that it's inactive, its native form, and can be activated using the Cre recombinase. What we noted is that the transgene integrated in 9 copies, and in the native state there are 9 inactive copies. If the Cre recombinase acts for a short period of time, then these copies can be activated. In the best case, we have 9 active copies. If it acts longer, then it's excised, and we end up with a single copy. So the short effect of Cre gives you higher expression levels, whereas the longer expression gives you decreased levels of expression. And that translates into the phenotype. So this is the long type of expression, VAV-Cre. The mice have high platelets but normal hemoglobin, so a ET phenotype. When we do a short pulse of Cre expression, then we get higher expression. We get a PV phenotype with high hemoglobin and high platelets. Also neutrophils go up. And here for comparison is the exon 12 mutant, which has very high hemoglobin levels but normal platelets. And here this type of phenotype is not linked to expression levels, but rather the exon 12 mutant seems to be qualitatively different from the V617F. This also translates into the fact that the PV model with the V617F mutation tend to then decrease hemoglobin levels after about 3 to 4 months, and this is due to increase of fibrosis in these mice, which then inhibits erythropoiesis. The exon 12 mutant doesn't show in the mouse model any of these signs of myelofibrosis. Instead, the exon 12 mutant optimizes erythropoiesis by making iron more available. Here in red is the exon 12 mutant, blue is the V617F. You can see that the transferrin receptor, messenger RNA end protein, goes up, and serum iron slightly increases. Hepcidin goes down, and erythroferrone goes up, showing that the exon 12 mutant just maximizes the availability of iron, so to maximize the production of red cells. So these models are quite useful and interesting. They illustrate that the mutant JAK2 also in the mouse model is variable in its phenotype and sort of reproduces the same variability we see in patients, sometimes having PV, sometimes ET phenotype. Part of this variability we can explain through different levels of expression, but there are still factors that need to be examined. In particular, why is exon 12 mutation different in its effect on phenotype from V617F? So in the last part of my talk, I would like to address one aspect of V617F pathogenesis, which is particularly interesting, and so relates to the earlier talks on the microenvironment and the niche where the stem cell is located. So this is the vascular niche where stem cells are located and can be maintained. And there's several different cell types that constitute this vascular niche for hematopoietic stem cells. One interesting cell is this Nestin-positive MSC, which is innervated by sympathetic nerves. And this is part of the reason why hematopoiesis shows circadian rhythm. So the production is undulating with the day-night cycle, and this is due to this innervation by the sympathetic nerves. So the story started actually with a pathologist in Basel who looked at the components of this niche in different diseases and noted that normally you see these nestin positive cells which are located around blood vessels, but in sections from patients with MPN, these nestin positive cells were largely decreased. We then collaborated with Simon Mendes Ferrer and Lorena Ranz in Madrid, and they have been able to show that in fact, also in the mouse model, when you transplant V617F expressing bone marrow cells into a mouse that has these nestin positive cells labeled in green, then you get a decrease in these nestin positive cells. This can also be shown at the level of RNA. These nestin positive cells are essentially massively reduced when the V617F cells are present. The mechanism of this is due to damage that the mutant cells exert on this connection here. So the mechanism has been worked out partially by Simon, and essentially it's probably IL-1 beta and other cytokines produced by the mutant cells that destroy these nerve endings and lead to the destruction of these nestin positive cells. What is quite amazing, what Simon then did was to rescue the phenotype using actually the ligand here. Normally it's noradrenaline or norepinephrine that is produced by these nerve endings, and the receptor on the nestin positive cells is a beta-3 adrenergic receptor. And so there are beta-3 agonists that can be given to a mouse or a human, and what he's observed is that giving this trophic signal here will then reconstitute these nestin positive cells. So we follow this up using a model, our mouse model, where we express the mutant JAK2, and we co-express GFP, green fluorescent protein, as a reporter gene in a competitive transplantation one-to-one with wild-type cells. So we can track not only the phenotype of MPN, but also the mutant allele burden. Now, when you treat these mice with either a beta-3 agonist, which in this case is called BRL compound, then we see no effect on the hemoglobin, but we see a decrease in platelets compared to the vehicle control, and also a decrease in neutrophils. This is the vehicle, and these are the beta-3 agonist treated mice. However, somewhat to our disappointment, the allele burden did not change in a major way. So the main effect was apparently mediated through the platelets. Interestingly, the vehicle-treated group then developed, as expected, myelofibrosis, whereas the mice treated with the beta-3 agonist had a markedly decrease or almost no fibrosis. So this was the basis to design a clinical study, which we performed with the Swiss Study for Clinical Cancer Research. And we asked whether symptomatic drugs can have an effect on JAK2 mutated MPN. It's a prospective single-arm multicenter study, phase 2. And here are the compounds. This is the compound that was used in the mouse study. There's a somewhat species barrier, so this compound doesn't work well in humans, whereas this compound, mirabegron, does not work well in the mouse, but they bind to the same type of beta-3 adrenergic receptor. So the study design was to include ETP or PMF and JAK2 positive, at least 20% allele burden in peripheral blood. Then we treated with 24 weeks of mirabegron. We were lucky because mirabegron actually is a drug that's on the market for irritable bladder, and so we used a dosage that was established for this type of application. And then we checked after 24 weeks for the endpoints, which were reduction of mutant allele burden, on secondary endpoints, reduction of allele burden below 25%, improvement of blood counts, or improvement of symptoms. I should also say that patients treated with interferon or ruxolitinib were excluded, but not patients treated with, for example, hydroxyurea. The results were at first somewhat disappointing because the primary endpoint of 50% reduction in allele burden was not reached. One patient had 25% reduction. The mean blood counts also were similar, and the adverse effects were mild and, as expected, mostly cardiac, so tachycardia, etc. However, as a sidearm, we had 20 of the 39 patients enrolled in the study of the bone marrow. They had bone marrow biopsy prior and at the end of the treatment. And interestingly, we saw in all patients, with a few exceptions, a decrease in the fibrosis grade, reticular fibrosis, and at the same time, this is before and after treatment, an increase in the nestin positive cells in these patients. So, in summary, here is an effect that the mutant JAK2 positive cells exert on the microenvironment. They destroy these afferent sympathetic nerves. This then leads to degeneration of these nestin positive green cells here, and that seems to promote the expansion of the clone. If you then provide the trophic factor that normally these cells need, which is beta-3 agonist, then these nestin positive cells seem to reappear, and they push back the clone to some degree. So this is sort of an encouraging sign that we can also influence the MPN clone indirectly by changing the microenvironment to its normal physiologic state. I would like to end here and mention the people involved. So the mouse project I've presented were performed by Lucia Kubovchakova and Jean Grisoire. We had collaboration with Lorena Arranz and Simon Mendes Ferrer in Madrid, now in Cambridge. And the clinical study was done with the Swiss Clinical Trial Organization, was supported by grants from the Gateway and the Rising Tide Foundation. And I thank you for your attention.